Good day, everyone. Welcome to today's webinar, ISA webinar. Happy that you are able to join. And I'm very pleased to introduce to you Dr. Dalia Tsimpida from the University of Liverpool, who will be presenting her work titled Global First Evidence, Uncovering the Real Prevalence of Hearing Loss in Adults Using Big Data from English Primary Care. This is a very important topic for all of us in the field. Dr. Tsimpida is a lecturer in public health at the University of Liverpool and also an associate fellow and a chartered member of the British Psychological Society, as well as a senior fellow of the Higher Education Academy. So I'm really, really pleased, Dalia, that you have taken the time to share your work with us. I give you the floor.
Thank you so much. Good afternoon to all. Good morning, good afternoon, good evening, according to the place you are at the moment. Thank you, Astrid, for your kind introduction. I am incredibly grateful for the opportunity to be here with all of you today. And the aim of this presentation is to share evidence from my latest project, which aimed to quantify the real prevalence of hearing loss in older adults in England. The findings I'm about to share hold immense significance as they shed light on an issue that affects countless individuals worldwide. The results we will discuss today have the potential to shape policies, interventions, and healthcare strategies to improve the lives of older adults affected by hearing loss. I am going to cover today 4 topics: the importance of hearing loss as a major public health issue, the current estimates of hearing loss prevalence in England, the preliminary findings from the project that aims to quantify the prevalence of hearing loss at the population level, and the major implications for public health, policy, and practice. As you all know, hearing loss is a major public health problem. It is a public health problem because the impact of hearing loss does not end with a person's ability to hear, as commonly believed. Hearing loss has many physical, cognitive, economic, and emotional consequences, and impacts the quality of life, mental health, work, education, family life, communication, and social life. It is the 3rd most common chronic health condition after high blood pressure and arthritis. And we saw in the health profile for England that it was the 1st leading cause of morbidity among adults 70 years and older, and the 2nd leading cause among adults 50 to 69 years old. So we can understand that it's not only an audiological problem, but a major public health problem. It is estimated that it currently affects millions of people in England and costs the English economy over 25 billion annually in loss of productivity and unemployment. While policymakers in England diligently collect data on individuals with vision loss and monitor population level changes annually, similar attention to hearing loss data is currently lacking. They also record all those who have diabetes and referred for eye screening, but unfortunately, the same level of attention is not given to ear screening. Despite the well-established link between diabetes and hearing loss, individuals with diabetes are not routinely referred for ear screening. Our current understanding of the true extent of hearing loss within the population is lacking accuracy, and we rely on estimates derived from age demographics to roughly estimate the magnitude of the issue. However, this approach fails to provide a precise assessment and leaves significant gaps in our knowledge. To give an example from England, the hearing health of the population is estimated by counting the number of older people in each local authority from national statistics, population statistics, and roughly estimating the percentage of those who may have hearing loss based on the percentage given in a study conducted 40 years ago, without taking into consideration the present and actual population needs. However, it is essential to gather and analyze data on hearing health problems in a more systematic way, just as we do for other health conditions at the population level. Furthermore, the accuracy of these estimates has never been validated with real-world data, yet still determines the local hearing health needs and consequently the resource allocation decisions, which is really important from a health policy and health equity perspective. Recent findings from my research showed clearly that the increasing trend in hearing loss prevalence is not related to the aging of the population, as traditionally believed, but potentially to social and lifestyle changes and population differences. The new national study of hearing we published last year also revealed vast differences in hearing loss prevalence among adults with similar age profiles, driven by socioeconomic position and the place of their residence. Therefore, the study highlighted that the regular assessment of the extent and causality of the population's different audiological needs is really supported by the updated evidence that our study has produced. Which basically makes sense, since we already know that hearing loss can occur at any age. Even if someone is young, listening to music at high volumes can be harmful to their hearing. The louder the sounds or the longer one listens to them, the greater the risk of damaging our hearing. Therefore, it is important to systematically collect and analyze hearing data, because if we don't measure hearing loss prevalence data, we can't monitor any kind of improvement or deterioration of population's hearing health. Because, as the quote says, you can improve what you don't measure. It is essential to gather and analyze data on hearing health problems in a more systematic way, just as we do for other health conditions at the population level. To address this, I'm now leading a new project that has received funding from Research England UK and the University of Liverpool. The project aims to better understand the local hearing health needs by analyzing for the first time big data from English primary care. As part of the project, I analyzed the hearing data of 2.7 million people living in 9 local authorities in Cheshire and Merseyside integrated care system in north of England to gain insights into the hearing health needs of this population. The project aims to quantify for the first time the severity of hearing loss in terms of prevalence and incidence using real-world evidence from Cheshire and Merseyside primary care, and investigate potential localized patterns, trends, and differences from the current NHS hearing loss prevalence estimates. So, to initiate the process, I systematically identified the specific diagnostic codes employed in primary care settings for capturing different types of hearing loss. It is essential to underscore that the data required for this analysis already exists and is readily accessible to public health professionals. Consequently, extracting these data from countries that maintain medical health records overseen by public health authorities is entirely feasible without the need for additional resources, equipment, or agreements. Going back to England now, analyzing data from 2.7 million individual medical records, I identified that during the study period from 2013 to 2022, the last decade basically, nearly 220,000 patients were recorded with any hearing loss issue. However, the results reveal vast inequalities in hearing health, which is not related to the aging of the population, as the results were age adjusted. Cheshire, this region, had the highest concentration of high clusters of hearing loss, which means that during the past 10 years, the 42% of the area is having high values of hearing loss, surrounded by high values in both space and time. And an estimated 43% of the population in this local authority lives in those areas. This is not surprising if you see this region. It is an industrial area, so probably noise pollution may be responsible for the higher prevalence in this region, which is not related to the aging of the population. This figure shows the trends of time series values of the prevalence of hearing loss from 2013 to 2022. We can observe three distinct clusters of areas with statistically similar values over time. This is called space-time pattern mining analysis. And these trends represent trends of high, medium, and low increase. We can see that all clusters, no matter how high, medium, or low rate of increase, were continuously increasing since 2013. So hearing loss prevalence is increasing. The important thing here is that hearing health disparities are increasingly widening over time because the gap is widening at the moment. And in certain regions, in brown color, populations experience a more pronounced decline in hearing health at an accelerated rate. We need to investigate all those reasons behind this rate because this doesn't have to do with the age of people living there. For example, Halton region, this in brown color, had the greatest percentage of areas with a high rate of increase, 40.38% of the local authority, showing that hearing health inequalities are widening more rapidly within that local authority. Nearly half of the population in Halton, 54.29%, which equals to nearly 30,000 people, is living in an area with a high rate of increase. You can see on the slide the average rate of the recorded hearing loss prevalence from 2013 to 2022, according to low, medium, and high rate of increase. We see clearly that hearing health inequalities are increasingly widening over time, and people living in the locations with the higher rate of increase in brown experience a more pronounced decline in hearing health. It is an alarming finding because it shows that hearing health is declining at an accelerated rate. This figure depicts the results of geographically weighted regression between index of multiple deprivation, is a proxy measure of the deprivation, the socioeconomic position of people and neighborhoods, and the prevalence of hearing loss in adults 50 years old and above in 2020. The darker areas in purple do not indicate where there is the highest deprivation or highest hearing loss prevalence. Rather, they reveal where the relationship between deprivation and hearing loss is the strongest. As we see, deprivation may be a strong predictor of hearing loss in purple, for example, in Wirral, this local authority, compared to areas in light blue, for example. The deprivation, this variable explains up to 35% of the variance in hearing loss in 2020 across the integrated care system. The robust correlation observed between deprivation and hearing loss is not attributable to variations in the age composition of the population within each local authority. One could say that in some areas we can observe higher prevalence rates because population living there is older, but this is not the case. And this can be clearly observed in the provided table, which demonstrates that each local authority has a comparable median age, indicating symmetric distribution of age profiles across the different locations. This is a really interesting figure because we can see that when examining individuals of the same age, such as 65 years old, for example, this axis shows the age, this axis shows the hearing loss, and with color you can see the categories of deprivation. So areas with higher levels of deprivation, indicated by a deep purple color on the right of the graph, tend to exhibit higher prevalence rates of hearing loss. This observation suggests a strong association between deprivation and hearing loss within similar age groups. You can see that a person, for example, 63 years old, can have different prevalence of hearing loss according to deprivation of the neighborhood they live. The consistent relationship between higher deprivation levels and increased hearing loss prevalence, even among individuals of the same age, provides further evidence that factors beyond the aging process contribute to hearing loss prevalence. Lastly, I employed an advanced methodology to estimate the projected prevalence of hearing loss over the next 5 years, from 2022 to 2027, based on the continuation of trends observed over the past decade. So no matter the limitations of the records, because not all people who have hearing loss have been recorded, but if things remain the same, this will be the situation in the integrated care system in 2027. This forecasting approach allows us as public health professionals to anticipate the potential trajectory of hearing loss rates and better prepare for future challenges in the field of hearing health. So you can see in a deep blue color the areas where the hearing loss prevalence in 2027 will be higher and up to 25%, which means that 1 in 4 older adults, 50 years old and older, will have a recorded hearing loss. The figure on the right illustrates the areas where inequalities also in hearing health are projected to widen significantly. You see differences between the prevalence rates across the region and according to the position, the location of people in the integrated care system. And this emphasizes the critical importance of monitoring the actual data on the population's hearing health rather than relying solely on age projections. Such monitoring is essential to address this urgent issue and implement targeted interventions effectively for the people who need most. According to the existing data in the NHS hearing loss data tool, although not directly comparable, but I calculated the increase in the number of people with hearing loss, where hearing loss prevalence is primarily attributed to age demographics. So the current estimates suggest that from 2015 to 2025, there was an 18.8% rise in the prevalence of hearing loss for people aged 50 years old and older. However, the increase rate based on the actual data, and actual data, I mean the recorded data in primary care, is 56.4%, 3 times higher increase rate, which is really alarming. Let's look now into the implications for public health policy and practice. The World Report on Hearing lists the identified priority areas for research in ear and hearing care. And one of the top priorities is to quantify the prevalence and the causes of hearing loss at the population level. This work aimed to contribute to the generation of knowledge regarding public health aspects of ear diseases and hearing loss following recommendations by WHO. This research has enabled us to delve deep into the realm of big data, extracting valuable insights that go beyond mere assumptions. By analyzing extensive primary care records, we have gained unprecedented clarity on the true prevalence of hearing loss. The findings are expected to bring a revolution in our understanding of this pressing issue, making a substantial impact on policy making, healthcare practices, and basically the lives of millions of people. There is also a recommendation for ministries of health to determine targets, monitor national trends, and evaluate progress. And determining the population needs and priorities is the first and most important step in order to set targets, determine indicators, and then integrate ear and hearing care indicators into health information systems. This monitoring is feasible through the national electronic health records that already exist in countries. This is a positive message because it doesn't require new studies, new surveys in countries, new resources, because the data already exist. Electronic health records are real-time, patient-centered records that provide immediate and secure information to authorized users, similar to the records that I analyzed for the purpose of my project from NHS system in England. The data exists, and in 2021, for example, on average, 93% of all primary care practices in OECD countries use the medical records, which means that the national health datasets are available and can be linked for monitoring and research. The World Report on Hearing recommends that WHO member states take urgent and evidence-based policy action to prevent, identify, and rehabilitate hearing loss. And this is really important because hearing loss affects the functional ability that improves well-being and affects the healthy aging of the population, the ability to live longer and healthier lives. The accurate recording of hearing loss issues in primary care records can be an important part for a sustainable hearing loss screening strategy for the early detection and intervention for hearing loss in older adults. The project provided a fantastic opportunity to get a better idea of the severity of hearing loss in terms of prevalence and incidence to support evidence-based policy making. During this project, we are working with local, regional, national, and global stakeholders to evaluate the evidence from the real-world hearing health data in England and identify a health policy roadmap to inform local, regional, national, and international health policies. The produced evidence is advancing now our knowledge of people hearing health and is expected to inform health policy making in the 9 local authority boundaries of Cheshire and Merseyside to meet the multifaceted needs of local people. I'm in a communication with the place directors of these local authorities to help me interpret the findings and understand the magnitude of the problem and collaborate to see what health policy changes may be needed. We also work at a regional scale with stakeholders from the NHR Applied Research Collaboration Northwest Coast, because according to the new National Study of Hearing we published last year, the burden of hearing loss in Northwest is one of the highest in England. And the insights from this project will inform the need for a re-evaluation of the actual hearing health needs of the population across the whole region. Also, we work with stakeholders from the National Disease Registration Service, NHS Digital, and this analysis will inform the NHS England and the Department of Health health policy strategies at a national scale. Finally, this work is going to inform current work at international scale, because all countries currently calculate the hearing loss prevalence based on the population demographics and not on actual hearing health of the population. The map shows the projection regarding the number of people with disabling hearing loss and estimated increase in 2030 and 2050. However, the data from my project, the evidence from England, show that the estimates that are based only on age are really conservative, since in England, the rate of increase is 3 times higher than the projections that are based only on age. This is because other factors, social and lifestyle factors, affect the hearing health of the population, and this is not related to the age of people. We should monitor these changes and act now to understand the magnitude of the problem in more regions and more countries. I analyzed the recorded hearing loss data, and I am aware that the problem may be 3 times worse than we currently believe, considering only the existing recorded primary care records. We need to take into consideration that not all people with hearing loss have been recorded in the primary care records I analyzed. For example, up to a third of older adults with hearing loss in England could be undetected and untreated, because these findings come from the English longitudinal study of aging, which is a nationally representative study. This study showed that a third of over 50s with hearing loss could be undiagnosed. Also, in our recent study, we found that nearly 40% of adults with a recognized hearing loss do not inform their hearing provider, which means that we miss the whole picture of those who are not aware of a hearing loss problem and those who are aware but don't inform their provider for many, many reasons. And we need to systematically monitor the issue, as it is the case with other diseases at the population level. Our recent study revealed the alarming extent of unaddressed hearing loss among older adults in England, particularly women, those in retirement status, those with foreign education, lower education, smokers, and heavy drinkers. So all these categories are people who are less likely to report a hearing loss. This is why quantifying and monitoring the severity of hearing loss at the population level is paramount and urges the integration of ear and hearing care into national health policies, strategies, and plans. Hearing health indicators should be included in the public health outcomes framework and be systematically collected, analyzed, and interpreted. These suggestions were included in the written evidence I submitted to the UK Parliament, providing evidence for the benefits of incorporating a hearing check into the NHS health check. Something that was also suggested in the proposal by RNID, the national charity supporting people who are deaf, have hearing loss, or tinnitus. As a proud member of the World Hearing Forum, I'm committed to work for a world in which no person experiences hearing loss due to preventable causes, and those with hearing loss can achieve their full potential through early identification and appropriate management of the condition. Quantifying and monitoring the severity of hearing loss at the population level is a really important step for this mission. And the time to act is now, because we cannot afford to ignore the impact of hearing loss on individuals and society. By obtaining a more accurate understanding of the scope of this challenge, we can allocate resources more efficiently, tailor interventions to specific needs, specific locations, and specific population groups, and ultimately improve the overall quality of life for individuals with hearing loss, so as to have the opportunity to achieve a healthy and active aging. In this presentation, I covered 4 topics: the importance of hearing loss as a major public health issue, the current estimates of hearing loss prevalence in England, the preliminary findings from the project that aims to quantify the actual hearing loss prevalence at the population level, and the major implications for public health, policy, and practice. At this point, I would like to thank my research team for this work, which has been funded by Research England, UK, and the University of Liverpool. I collaborated for this work with the co-investigators, Dr. Roberta Pirodi, Dr. Konstantinos Daras, Dr. Gabriela Melis, and Professor Benjamin Barr. Thank you very much for listening. I'm happy to answer any questions you may have.
Thank you very much, Dalia. This was a really important talk and very interesting data. The floor is now open for questions, and there's a first question in the chat, in the Q&A. Please add your questions to the Q&A or to the chat, or just indicate that you would like to put on your microphone. But the first one is from Nikolai Biscard, who asks, the data you have analyzed comes from primary care, I understand, and not from a balanced sample of the population as such. The growing number of people diagnosed with hearing loss could be because more people seek help for a hearing condition rather than a growth in prevalence as such. What do you think, Dalia?
Yes, thank you so much for this question. I have previously analyzed survey data from the English longitudinal study of aging, which is a nationally representative data set. So this gives us enough confidence to understand that this is closer to the real picture. So the data from primary care are lower than the data indicated by English longitudinal study of aging. This shows to me that the whole picture in primary care is not reflected in the existing data. And this is for reasons I mentioned in the limitations that have to do with people not going to the doctor to report a hearing loss issue, or for cases that where people are unaware of a problem, so as to mention that and to be recorded. So the data we have vary significantly across regions, and show that there is a lot of work to be done to have a percentage that is at the moment 16% from primary care data, and should be close to 25% according to survey data. So there is a lot of work to be done to better capture all the hearing loss cases and not have only estimations from surveys.
Thank you, Dalia. So there's a question from Bernadette Felton. It's about the interaction you identified between hearing loss and deprivation. How do you define deprivation? Is it socioeconomic or geographical access or other? I was going to ask the same. So yeah, interesting question.
Yeah, this is a very interesting question. So I used the index for multiple deprivation that is frequently used in England. You can see the indicators that this index is consisted of. So this reflects several factors at the neighborhood deprivation and the socioeconomic position of people living there. Of course, we cannot understand that this, if someone lives in a deprived area, automatically is a person with low socioeconomic position as well, because this is a neighborhood score and not an individual score. I use this index because this is used for linkages and analysis in primary care for other conditions as well, from the national estimates, Public Health England. So it is a well-defined and respected indicator to reflect the neighborhood deprivation.
Thanks. And then there's a question, it's all good detection of hearing loss, but the end factor is provision of hearing aids. Is this a comment or is it a question, or would you like to comment on that, Dalia?
Yes, I think this is important because we need to understand the magnitude of the problem, not only for prevention purposes, but also for the early identification, so as people can have the opportunity to be referred for hearing aids within the system, to be able to navigate within the system. These maps can be useful, for example, for hearing aid providers, understand the areas where people have a higher prevalence, and this probably may mean that they can organize campaigns to raise awareness, they can monitor these regions, and they can tailor some resources to these areas, because for several reasons, the population living there has increased needs.
Yeah, that is true. But from the same person, the comment comes that hearing aids are very expensive, and so that many might not be eligible, might not be able to buy them. Personally, I always thought that in the UK, there is you can acquire hearing aids without too much cost, but maybe I'm wrong. Maybe you can comment on that, Dalia, or maybe it's out of your field.
Yes, hearing aids in the UK are provided for free. So the important thing is for the person to reach the level of primary care, and then can be referred for free to get access to free hearing aid. We have this privilege in England. I'm aware that this is not the case for many countries. Yeah. But for my personal opinion, it's better to highlight the magnitude of the problem, so as countries relocate resources to this hearing health need. Because otherwise, people in health policy may take decisions that are not informed by accurate data.
Yes, that's very true, Dalia. So I would like to present a question by Mark Laurijns, who says, we see more and more studies indicating that the prevalence of hearing loss per age group is declining in most of the Western countries and more prominent for men. Is this a conflict with your findings? Or does it confirm that the age effect is more related to exposure or socioeconomic factors? And he thanks you for your great talk too, Dalia.
Thank you so much, Mark. This is a very good question. I think these studies are not directly comparable because rely to samples that have been taken to gather a picture of the problem, but cannot be nationally representative. In my opinion, there are many reasons for hearing loss, and not only the age of people. Of course, there is a higher prevalence as people grow older, but age is a proxy of the situation they have been lived during their lives, and not a factor per se that defines that people have a problem. You mentioned a decline for men. I would say that this may have to do with lower prevalence of report for men. And I am aware of a recent study that says that women after menopause have increased hearing loss due to hormonal imbalance. So this is another factor that shows that it is lifestyle and social factors that define hearing loss, and not the age as we previously believed.
Thank you, Dalia. And when you speak about the prevalence of hearing loss in men, it might also be the case that they are not so exposed to very loud apparatus as they were in the past, maybe working in factories or under very noisy conditions, because those regulations have improved over the years. That could be another factor.
That could be another factor, but I'm aware that the data from England show that those working in manual occupations, men working in manual occupations, are up to 2 times more likely to have hearing loss compared to people who don't work in manual occupations. So I would be a bit skeptical to see the representativeness of this data, because from what we have seen, there are many cases of not reported hearing loss, which hides the real burden of the issue. So in primary care data, we can see the tip of the iceberg, and many cases are hidden within the iceberg.
Yeah, that's completely right, Dalia. True. Dalia, would it be possible to show the leaky pipeline slide again? Thais Murata is asking that. She
Yes, sure.
says, I do not understand if a patient does not complete treatment or do not get to the point where they get the hearing aids.
Just a moment.
Good question.
Can you see my slide?
Yes, yes, thanks.
Okay, so with colleagues, we depicted the several stages in the leaky pipeline of hearing care, as we named that, from primary to secondary care evidence from the English longitudinal study of aging. So we named the stages as the first stage to acknowledge hearing loss, then to go to primary care and disclose it to a primary care provider, then to be referred from primary care provider to secondary care, to ENT and audiological examination, to be recommended to use a hearing aid, to actually go and get a hearing aid, and to actually go and use the hearing aid most of the time or some of the time. So we see that we lose people in each of these stages, either in primary care, in the first stages of recognition, disclosure, and referral, and then for the concordance with the recommendation. And these 6 stages show the areas where interventions are needed to improve awareness, not only for the patients, but also for providers, because we found that 1 in 5 primary care professionals do not refer for audiological examination because they may probably have misconceptions about the etiology, and so they don't follow the guidelines who say that they should refer people when they identify any hearing loss issue. Thais, do you have any specific question for the leaky pipeline? I hope I answered your question.
Yeah, the question in the chat is, I do not understand if a patient does not complete treatment or do not get to the point where they get hearing aids, but I think,
The percentages in each stage show the percentage of people who do not complete the stage.
Okay, thank you. Thank you for replying to that one, Dalia. There's also Thais is saying, I'm going to look at the paper. Then there's someone who asks, how similar are these patterns for hearing loss compared to other health conditions, diabetes, cardiovascular, etc.?
This is the first step of analysis. My next step, my future plan includes to analyze patterns for hearing loss compared to depression. So starting with depression, because I have done previous work with survey data. So this is a good opportunity now to see the correlation and the common factors of comorbidity between hearing loss and depression. And of course, I aim to continue with more diseases like Alzheimer's, dementia, diabetes, cardiovascular disease, and other conditions that are commonly comorbid with hearing loss.
Thank you. Thanks a lot, Dalia. Well, your very interesting talk and a very important talk has spurred a lot of questions, and thanks for your discussion. You're going to move forward quickly, I think, in the coming months, and we're going to invite you again to present because it is really very exciting work. Thank you. Just another one coming in. Nikolai says, I think it's well recognized that people with similar pure tone hearing loss can have a very different experience of a hearing problem. Do you think we should focus more on functional testing rather than pure tone tests? Many people do not have normal hearing, but yet, or do not have normal hearing, but do not experience any problems. Yeah, that's another important one.
This is really important, and I am on the same page with you, Nikolai, but we need to take into consideration that there is a first step to screen people about a potential hearing problem, and then to go to diagnostic test, and this is under discussion. Of course, we have seen several recommendations by WHO, recommendations for considerations for screening. So I think we need to focus first at the point where we should screen people, identify people who may have a hearing problem, and then to refer them all for a further audiological examination, which of course can include functional testing, pure tone tests, to understand not only the central hearing, but also peripheral hearing and the potential difficulty in auditory processing disorder.
Yeah, I agree. Let me see. What difference do you think, there's the questions coming in, Dalia.
Yeah.
What difference do you think it would make if there were universal hearing screening as recommended by WHO?
Yes, so this is important. I think this would highlight the issue so as to raise awareness and for policymakers to understand that this needs to be closely monitored. By WHO, important is the impact of hearing loss on the population.
Dalia, I think there's a
how
delay on
this
this.
affects not only local conditions of we have the evidence that link with dementia, considering hearing loss from a communication perspective, diabetes and loss is not too wider to understand the medical diagnosis, to understand the guidance, the recommendations about medications. There is a quote saying that 15 and 50 sounds the same in healthcare settings. So considering hearing loss not only as an audiological issue, but as a patient-centered issue will definitely improve the health of the population in general. And in terms of health policy, this will lead to allocating more resources, and this will lead to health equity, because people need to have the resources and the care they need according to their personal needs, and not according to roughly estimates at the population level.
Thanks, Dalia. We didn't catch all of it. I don't know if it applies for everyone, but on my side, there was a problem with your understanding you for a short while, but then we got the gist of your answer. There's still a question on, do you have any suggesting for improving the interprofessional teamwork in primary care, since audiologists are often working in a silo? Now, that's an important one too.
Yes, this is important, and this will be hopefully a result of understanding the magnitude of the problem if we apply universal hearing screening. Because at the moment, the problem is hidden, and even health professionals in primary care don't really know and understand why this is an important public health issue. So this will work in both ways. The increased understanding from screening will improve the awareness within the healthcare system. Regarding interprofessional team, I think this would be beneficial, but it all starts with from primary care and universal health coverage. And I would say that the first step would be to raise awareness in primary care providers. And then if they are aware of the importance of this issue, they will be able to refer to audiologists and to mental health professionals if there is a correlation between hearing loss and depression, for example, or to refer for a cognitive examination if they are aware that there is a link between hearing loss and dementia. So I wouldn't propose more resources and more work to be done so as to delay changes, but the focus should be on raising awareness within existing professionals and the resources.
Yeah, I agree with you. I agree with you, Dalia. One more question. Are hearing aids actually part of the problem, since most people want solutions to hearing problems but do not want to use the hearing aid due to stigma? What do you think? What are your views on this?
I think it's a complex issue, and basically the way that we calculate at the moment the hearing loss prevalence that is based on age projections is potentially a reason for this stigma, because this calculation 50 and 40 years ago was an insightful and helpful measure to calculate hearing needs at the population. But over time, this calculation contributed to hearing loss to be considered an inevitable part of aging process. So people may not want to be considered old, and that's why sometimes they don't disclose a hearing problem and they don't want to use a hearing aid, which doesn't make any sense for vision loss, for example, because we never linked vision loss with aging, basically.
Yeah, you're right, and this is a problem that might be addressed by the much smaller hearing aids now that you can wear in the ear, and other ways to amplify the sound. Dalia, I think you have really given a wonderful presentation, spurred a lot of discussion. On behalf of all the people attending, I would like to say a huge thank you for your presentation, for your discussion, and also the attendees for taking part in this discussion. It's important and relevant for all of us. So we have a lot to think about, Dalia. You have taught us a lot today, and hopefully you will see your work continued in the future, and we can listen to what comes out of that in next year when you have time again to share with us. Thanks a lot.
Thank you
And
so much. It was a fantastic opportunity to present these findings. And thank you all for participating today and for very important questions.
yes, thanks to all, and stay safe. Thanks, Dalia.
Thank you.